EGFR and HER2 are two very similar genes. They're highly homologous. And in fact, you can line up the exons between EGFR and HER2, and they really map one for one. But there are some differences. So EGFR often gets these exon 19 deletions and this L858R. Those same mutations don't occur very frequently in HER2. Instead, HER2 almost always gets exon 20 mutations. And they most commonly get insertions. There's one insertion, the 775 YVMA, that's really the most prevalent. YVMA refers to the amino acids, the 4 amino acids that are inserted there at that particular location. HER2 mutant lung cancer, these exon 20 insertions, also do not respond to the standard drugs that are available. Now, we don't have any HER2 tyrosine kinase inhibitors that are approved for lung cancer, but for breast cancer, there's lapatinib. Lapatinib does not appear to be effective. Afatinib, which is an EGFR inhibitor, also inhibits HER2 under normal circumstances. It inhibits wild-type HER2. It does not seem to inhibit exon 20 mutant HER2 in regular clinical use. And there's always excitement about antibodies like Herceptin or trastuzumab. And trastuzumab by itself does not appear to be particularly effective for HER2 exon 20 insertion non-small cell lung cancer. So again, this is a space that really needs new therapeutic options. It needs new targeted drugs. And so that's been an area of active investigation for us. Right now, the options that are available for any non-small cell lung cancer patient, namely chemotherapy and immunotherapy, are available to patients with HER2 exon 20 insertions or EGFR exon 20 insertions. But what we really are looking for are targeted agents that can help these. And targeted agents, because they specifically home in on the gene that's altered here, HER2 or EGFR, depending on which one. But because they have the potential to give much durable benefit, much deeper responses, a higher likelihood of response, if we're able to develop effective inhibitors. And we've certainly learned this from EGFR and ALK and BRAF and other diseases where targeted agents can really be spectacularly effective. So that's why finding inhibitors for HER2 exon 20 mutant disease or EGFR exon 20 mutant disease is such a pressing need. I think it's also worth mentioning that while we're focused on lung cancer in my group, these HER2 and EGFR exon 20 mutations occur in a wide variety of other diseases. It's well known that HER2 exon 20 insertions occur in breast cancer, and that's one of the most common places, but they also occur in gastric cancer. These mutations occur in glioblastomas, in adenoid cystic cancers, in a whole variety of different GI malignancies. In fact, we've recently gone back and reviewed the molecular profiling from MD Anderson, and we've identified more than 20 tumor types that have EGFR or HER2 exon 20 mutations. So while lung cancer has the greatest absolute number, if you look as a total, there's more non-lung cancer exon 20 mutations than there are lung cancer exon 20 mutations. So this is a case where things we learn from lung cancer actually can benefit all these other diseases as well. And we've seen this happen time and time again. An example for BRAF in melanoma, and there was a lot learned about that that's now been applied to lung cancer with BRAF mutations. What's exciting to us is recently there was an approval for a TRAC inhibitor or an NTRAC inhibitor, entrectinib, and that is across different histologies because those tumors occur in all different histologic subtypes, or I should say those mutations occur in all different histologic subtypes. And this seems to be the case with exon 20 mutations. They occur not only in lung cancer, but they occur in a wide variety of other cancer types. Well, right now we don't have any approved agents for exon 20 mutant disease. So we've set apart the last few years really screening all the available drugs, even looking at drugs that have been discontinued in the past for other applications to see if any of those could be repurposed for exon 20 mutant disease. And we identified one drug, poziotinib, and this is a drug that had previously been tested in breast cancer and previously been tested in lung cancer for standard mutations or the standard resistance mutation T790M. And it had activity there, but it was not better than the standard drugs that were out there. So the drug was discontinued for lung cancer testing based on that. Well, we found out that even though the drug did not distinguish itself as an EGFR inhibitor or a T790M inhibitor for the classical or standard mutations, it was highly active against exon 20 insertions. From a lot of molecular modeling in our group and testing in vitro and looking at mouse models, I think we've come to appreciate that among all the drugs that are at least approved, poziotinib was significantly more potent for exon 20, even if it wasn't as good for all the other types of mutations. And so this is what has prompted us to initiate a clinical trial that we've recently reported on the results of.